Welcome to the training on Continuity Assessment and Record Evaluation, also known as the CARE tool. This training was originally developed by the American Healthcare Association and the National Association in Support of Long-Term Care for their joint work group to measure therapy outcomes. The work group was assembled for the purpose of investigating a functional outcome measure that could be used by therapists and therapy companies across the industry. The work group focused on the CARE tool due to the significant amount of research and data that already existed, which we will talk more about in just a few minutes. AHCA and NASL gave permission for Optima Healthcare Solutions and Rehab Resources and Consulting to update the training materials so it could be used by a larger part of the rehabilitation industry who is interested in finding an outcomes tool that will enable them to measure and improve upon rehabilitation outcomes. This is the first of 3 trainings in the series. In order to make your training session more meaningful, you should have with you the CARE Item Set Training Manual, and within this manual is a lot of helpful information, such as the CARE Item Rating Instructions, a chart that defines each CARE item, as well as each CARE rating for that item, and at least 2 or 3 clinical vignettes for each CARE item to illustrate how the ratings would be applied in a clinic setting. Finally, you will be required to take the CARE item post-test. This will test your knowledge of the material presented. Why do we test? Because it is important to ensure that each person using the tool understands the definitions of the CARE rating scale. Because everyone is receiving the same training, the ratings are more consistent. It also ensures the data collected is consistent. One of the project's goals is that we can begin to assemble a database of information across companies and across the nation so that we can truly measure clinical outcomes for our patient populations. This first step in accomplishing that goal is to have consistent measurement scales and consistent items. The training and test also ensures that you, the therapist, understand what each CARE item includes and does not include. As therapists, we may have different ideas about what is included in the task of eating or in the task of bed-to-chair transfers. This training will define exactly what functions the tasks or items include, so we can all measure the same thing. Finally, the training will provide to each PT and OT examples and a clinical algorithm to use when assessing each CARE item. Some therapists listening to this training may never have heard of the CARE tool. Let's take just a few minutes to review what the tool is and why it has become so significant. It is important for therapists to understand why they are documenting information and how it might be used. First, the word CARE stands for Continuity Assessment and Record Evaluation. The CARE tool is a set of data elements that was developed after Congress called on the Centers for Medicare and Medicaid Services, which you may know as CMS, to develop one comprehensive patient assessment instrument that could measure health and functional status across the post-acute care continuum. Many of you may be familiar with the Minimum Data Set, or MDS, the Outcome Assessment Instrument Set, or OASIS, the Patient Assessment Instrument, or PAI. While the Long-Term Care Acute Hospital Setting, or LTAC, doesn't have a tool like these, they do collect certain pieces of information upon admission that categorize the patient's condition. The original goal of the CARE tool was to eliminate the need to have separate tools in each of these settings. Congress wanted CMS to determine if one tool could be used in each of these settings. You can imagine how helpful that would be to doctors, nurses, and therapists to have one tool that asks the same questions all along the way so we could begin to talk in a universal language rather than our own setting-specific terms. So CMS contracted with the Research Triangle Institute, or RTI, to develop this instrument. Between 2007 and 2010, the Patient Assessment Instrument was piloted across the country by all 4 post-acute care settings in a demonstration project called the Post-Acute Care Payment Reform Demonstration, or PAC-PRD. The CARE tool itself was designed to collect standardized information at discharge from acute hospitals and at admission and discharge from the 4 post-acute care providers, the LTACs, IRFs, SNFs, and home health agencies. Overall, the demonstration found that decisions about which PAC setting to send patients to who are treated for the same condition in acute hospitals is highly dependent on the availability of which post-acute care setting option the patient has and what they call other factors not measurable in the Medicare claims data. So in other words, they suspected that the decisions were not highly dependent on the patient's condition or diagnosis. The functional items on the tool were found to have good reliability and validity. The clinicians who participated in the demonstration gave mostly positive feedback on the tool and its items. Therapists reported they liked the specificity for measuring change in function that the items gave them. The degree of inter-rater reliability was found to be high, as well as the validity of the items. So in other words, the tool measured what it was intended to measure. The data gathered in this study has since been analyzed and made public in 2 separate reports, one delivered in May of 2011 and the other in November of 2012. Now, this training is not intended to cover the entire CARE tool, but rather a specific set of questions from that tool. First, we will introduce the CARE tool rating scores and their definitions. Then we will briefly review the CARE tool items that are scored. There are 2 sections, self-care and mobility. As you have probably already noticed, there are no items specific to speech therapy. That is because there was not enough data from the items on the CARE tool related to cognitive functioning and/or swallowing to support them as valid and reliable measures. After completing this training on the general items, you will be directed to take a post-test. It is important for every person who is collecting CARE, self-care, and CARE mobility data to be certified. Basically what this means is that you must go through this training and take a post-test. We want to ensure that everyone using the scoring methodology is using the same definitions and understands the items. This ensures the reliability of the data collected. So, everyone using the CARE functional item set must complete the general training. That is step 1. The next step is dependent upon your company's protocol. So you will want to be sure you know which path to follow. There is a learning module for the self-care items and a separate learning module for the mobility items. Some organizations will have OT trained to do the self-care item set and PT trained to do the mobility item set. That means for each patient, those would be the only items each discipline would complete. So if a patient was only being seen by OT and not physical therapy, then there would be no mobility items collected on that patient. Some organizations will have PT and OT trained to be able to complete both sets of data. Once you have completed the learning modules for one or both of these as directed by your company, you will need to complete the post-test. Each of the 3 learning modules has a separate post-test that must be completed. Everyone must score at least 80% on each of the 3 modules. An 80% score is similar to other certification requirements, such as the FIM testing. At the end of the online version of the test, you will be told what your score is. And if you achieved 80%, you can move on to the next test. If you scored less than 80%, you will be allowed to take the test as many times as you need in order to achieve the passing score. At the end of the online version of the test, you will be told which questions you answered incorrectly, so you can study those items before taking the test again. However, you will be required to take the entire test again, rather than only re-answering those questions you missed. Lastly, the test is an open book test, which means you can use your training manual and your notes from these training modules to assist you in answering questions. Once you have completed all these steps, you are certified to begin collecting the care item data on your patients. It is important to collect this information at evaluation and discharge of your patients. However, that does not preclude you from measuring these items during the episode of therapy, such as at reevaluation or progress report updates, because it is important to know whether your patient is progressing throughout the episode, not just at discharge. So let's begin to look more closely at the care item coding system. In other words, how the items are rated. Each task or activity is rated on a 6-point scale. This might be different than what you are used to using. Many therapists may be used to using a 7, 8, or even 9-point scale. The same level of assistance rating scale is used for both item sets, the self-care and the mobility. A higher rating indicates the patient has more independence with the task or activity. A 6 on the care item rating scale indicates independence with the task or activity, and each number less than 6 represents increasing levels of dependence. Next, let's look a little more closely at each of these levels and what they mean. Independent means the patient completes the task or activity by him or herself with no assistance from a helper. Setup or cleanup means the patient completes the task activity themselves, and the helper is only needed for assistance before or after the task. Supervision or touching means the helper provides verbal cues or touching or steadying assistance as the patient completes the task. The main differentiator between 4 and 5 is that in 4, you are providing some level of cueing or assistance during the activity. And in order to achieve a score of 5, the therapist is only helping a patient before or after the task. Also, notice that it does not matter whether the patient uses an assistive device or any kind of adaptive equipment, such as a walker, cane, railing, reacher, or anything else. Using these devices or braces is not factored in. Only the level of assistance or help that you provide is factored in. Partial or moderate assistance means the helper provides less than half the effort. They may lift, hold, or support the trunk or limbs, but the patient still is providing most of the effort. Substantial or maximum assistance means the helper does provide more than half the effort to complete the activity. And of course, dependent means the helper does all of the effort, and the patient does none of the effort to complete the task or activity. Now, you might be asking, well, what do I do when the assistance I provide is exactly 50%? If you feel that way, then use your clinical judgment. You might also think about other aspects of the task. In other words, are you providing cues, prompts, steadying? Other types of assistance should be factored in. It's not just about the physical assistance levels. It's also important to consider the safety and quality of performance for all the items. In other words, if the helper's assistance is required because the patient's performance is unsafe or of poor quality, the rating selected should reflect the amount of assistance provided. And it's also important to keep in mind that tasks and activities may be completed with or without assistive devices. So, for example, at evaluation, a patient may require a platform walker to ambulate due to a fractured right wrist and left tibia. The patient requires less than 50% assistance to ambulate 10 feet safely. At reevaluation, the same patient advances to a rolling walker with ambulation after being allowed weight bearing through the wrist. The patient still requires less than 50% assistance to ambulate 20 feet safely. At discharge to home health therapy, the patient is ambulating with a straight cane for 30 feet, but still requires less than 50% assistance to complete the distance safely. So as you can see, there have been changes in the patient's performance, but the care rating is still a 3 all the way through. For each task or activity, the therapist should assess the patient's level of independence. Another key point to remember with the care item scale that may be different from other rating scales you have used is that the rating chosen should reflect the patient's usual level of performance with the activity over a 2-day period. So if a patient is only seen on one day, such as an evaluation, then the rating is based on the patient's usual performance during that day or during your evaluation session. Let's look at an example of applying these ratings. During a 45-minute evaluation, the patient transferred out of bed to a wheelchair for transport to the therapy gym, which required substantial or maximal assistance. The patient stood from the wheelchair to the parallel bars, requiring substantial or maximal assistance. The patient transferred from the wheelchair to the mat table for supine exercises and required partial or moderate assistance. After the patient completed the exercises and transferred from the mat back to the wheelchair, he or she required again substantial maximal assistance. So using the information you've been given, take a few moments and determine what you would rate as the patient's usual performance for sit-to-stand and chair-to-bed-to-chair transfers. In this example, the usual performance also happens to be the lowest performance. So for sit-to-stand, the best answer would be substantial maximal assistance, and for transfers, substantial maximal assistance. Let's look at another example. During a 45-minute evaluation, the patient transferred out of bed to a wheelchair for transport to the therapy gym, requiring partial or moderate assistance. The patient stood from the wheelchair to the parallel bars, requiring substantial or maximal assistance. The patient transferred to the mat table, requiring partial, moderate assistance. The patient completed the exercises and then went back to the wheelchair and required substantial or maximal assistance. So using this information, what would you determine to be the usual performance for sit-to-stand? The answer would be substantial or maximal assistance. What is the usual performance for chair-to-bed? Partial or moderate assistance. So in this example, the lowest performance is not the usual performance. Next, we want to review what to do when an item cannot be rated. First, it is very important to point out that every effort should be made to score all items with a 1 to 6 rating. Use your clinical judgment when assigning the scores. Perhaps there are some tasks that cannot be attempted because the patient is actually dependent in those areas. The correct response would be dependent rather than not applicable or not attempted due to safety concerns. For example, if a patient is dependent in upper body dressing and they refuse to attempt lower body dressing, the therapist could probably assign a dependent score to lower body dressing as well based on the natural hierarchy of function. So we have an alpha score system for these instances. S is used when the task is not attempted due to safety concerns. N, if it's truly not applicable to the patient. A, when the task is attempted or unable to be completed. And P, when the patient absolutely refuses to complete the task. Even if a particular task or activity is not going to be the focus of your therapy program, you must still score the items. Why? Because if there is one thing our professions have learned over the years, is that we must have information on our patients in order to be able to support that we, therapy, made a difference in the patient's outcome. Without the data, we do not have a strong argument to make. When we score tasks or items as NT or not tested, or NA, not applicable, we downplay the role we have on a patient's overall level of function. Furthermore, the care item scores add up to be a composite score of the patient's overall function. So if items are left not scored, then the patient's overall level of function in self-care and mobility will be lower than they should be. So while we have alpha scores for those times where it is just not appropriate to assign a numeric score, keep in mind that these codes should be used minimally. So how is the alpha score S used? You want to choose this score when the task or activity is not attempted due to safety concerns and the therapist cannot infer what the patient's level of performance would be from another part of the evaluation. For example, an Alzheimer's patient becomes severely agitated after you have assessed bed mobility and before any gait training or transfers could be assessed. Walking and chair-to-bed transfers then might be scored an S. How is the alpha score N used? You choose this when the task or activity is clearly not applicable to the individual. So in other words, the person is not expected to perform the task now or in the future. A few examples of when it would be appropriate to use the N score would be if you are evaluating a double amputee patient who is not a candidate for prosthesis, then he or she would be rated N for putting on and taking off footwear. Perhaps a patient lives in a home that does not have a tub or a shower, or your facility does not have tub or shower facilities in which to test the patient. The patient only bathes at bedside or by the sink, so the item shower bathe self would be correctly coded N. And lastly would be a patient who exclusively uses a wheelchair and for whom walking is not a realistic goal. Any item relating to walking and going up and down the steps would be coded an N. A few examples of when it would not be appropriate to use N would be if you are evaluating a patient who can't reach down and put anything on their foot due to hip precautions. In this instance, the patient would be rated as a 1 or dependent because they cannot do the task. And just like in the last example, you may have a patient who only uses a wheelchair on evaluation. But in this example, the plan of care does include returning the patient to ambulation. Therefore, the walking tasks and going up and down the steps would be rated as a 1 or dependent. How is the alpha score A used? It should be chosen only if the task or activity was interrupted or stopped for reasons other than the patient's ability to perform the task or activity. Examples of when this might occur are if a family visits in the middle of your evaluation session, or the patient had to leave to attend another appointment. Perhaps the patient had to receive a medication that interrupted your evaluation, or equipment that was necessary to evaluate the task or activity fails. Preferably, the evaluating therapist should be able to go back to evaluate the area. This rating should be rarely used, but in all cases, use your best judgment. Next, we want to look at some scenarios when 2 responses might seem appropriate. Again, these situations should be the exception, but let's look at how the clinical analysis might be done to choose a rating. A patient has a PICC line that is not supposed to get wet. 1 or dependent is defined as helper does all of the effort, patient does none of the effort. But, as in this case, if a patient cannot perform a task or activity due to his or her medical condition or medical restrictions, and others would have to help him or her complete the activity safely, then this patient would be coded as dependent. What if a patient fails one task or activity, and that task or activity is logically related to another task activity? In these cases, it would be appropriate to code the patient as dependent in the related task. For example, if a patient cannot go up one step or curve without maximal assistance, then the patient would also be coded dependent for 4 steps and 12 steps. Another example is if a patient cannot walk 10 feet on an even surface, then the patient would be correctly coded as dependent in the item walk 10 feet on uneven surfaces. The last alpha score is P. P should be chosen when the task or activity was not completed because the patient refused to perform the task or activity. Clinical judgment should be carefully applied to these situations in order to determine if the refusal was due to the patient not feeling safe, or because he or she was concerned about not being able to accomplish the task. If that's the case, the item should be rated as dependent. Again, this rating should be rarely used because the evaluating therapist should attempt to go back to evaluate the task or infer performance from similar activities or apply clinical judgment as in the examples that we've already discussed. Lastly, let's discuss other data sources for rating the care items. First and foremost, the rating should be based primarily on the assessment of the patient and direct observation of the task or activity. However, if the task or activity cannot be directly observed, then information from the medical record or from staff observations can supplement your process. For example, it may be necessary to talk with nursing and/or review the record to assess a rating for toilet hygiene, chair, bed-to-chair transfers, and/or toilet transfers. If you assess a patient who is unable to transfer chair to chair or to a standing position, then you may want to check with nursing or the nursing assistants before deciding to infer the patient would score the same for toilet transfers and car transfers. Finally, before we end this training module, we want to review what the actual items are in the care self-care item set and the care mobility item set. In the self-care set, there are items for eating, oral hygiene, toilet hygiene, upper body dressing, lower body dressing, washing upper body, shower or bathing self, and putting on and taking off footwear. In the mobility set, there are items for lying to sitting, sit to lying, rolling left and right, sit to stand, chair or bed to chair transfers, toilet transfers, longest distance walked and longest distance wheeled, picking up an object, car transfers, walking 50 feet with 2 turns and walking 10 feet on uneven surfaces, as well as going up and down 1 step, 4 steps, or 12 steps. Now it's time to take the test. As stated earlier, all occupational therapists and physical therapists will be required to complete this post-test, which tests your knowledge of the rating definitions and alpha scores. Most therapists will take the test electronically. You will find the electronic link provided in your training manual. However, some companies may choose to test therapists using other methods, such as paper and pencil. So if you don't find the link in your manual, check with your managers. For those of you completing the electronic test, complete Section 1, Care Items General Questions, which consists of 6 questions. You are required to score no less than 80% to pass the test. You can use your training manual and any notes you took during this training to assist you. Your score will display on the last web page after all questions have been completed, so you will know immediately how you did. You will be required to take the test again if you do not score 80% correct, but you can take the test as many times as you need to. This concludes the general training module. Good luck!